Okay, thank you. We're back, Senate Health and Welfare, and we're looking at S47, bill related to mental health and transportation issues. And Katie McClin, why don't you introduce yourself for the record, and we'll get a little walk through the bill.
Sounds good. Katie McClin, Office of Legislative Counsel. I'll share my screen and I'll pull up the bill.
Okay.
Are you seeing the draft?
Yes.
I suppose I shouldn't call it a draft. It's a bill. This is not a draft.
It's a bill.
Okay, great. So as you mentioned, this is an act relating to the transport of individuals requiring psychiatric care. And I might just step back for a minute and sort of give you a big picture before we just dive right in and look at the language. So when we're talking about the mechanism for having an individual receive involuntary psychiatric care, through the civil system, there are a few different ways for that process to get started. The most typical way is through an emergency examination, and that requires a certificate by a licensed physician. In some circumstances, the licensed physician may not be available. However, either perhaps a law enforcement officer or a mental health professional is observing the person and sees that this person is potentially a person in need of treatment, which is a defined term in statute to mean somebody who is at risk of harming themselves or harming another person. Then what they can do is a warrant process, which means instead of getting that licensed physician certificate, the person can be taken into a temporary custody if a court weighs in and issues that warrant, and that person would be transported to a hospital to receive an initial examination by a licensed physician to determine if that person should be held for further examination and potential commitment for involuntary treatment. So that's sort of the framework of what we're working in. And so as you'll see, this first section 1 deals with the warrant. So it says in existing law, if in an emergency circumstance where the certificate, where certification by a licensed physician is not available without serious and unreasonable delay, and when personal observation of the conduct of a person constitutes reasonable grounds to believe that the person is a person in need of treatment, the person presents an immediate risk of serious injury to self or others if not restrained, a law enforcement officer or mental health professional may make an application not accompanying the physician certificate to a superior judge for a warrant for the examination. So for the most part, that's existing law. We're adding some gender neutral language, and we're specifying that the physician is a licensed physician in that first paragraph. But otherwise, not making significant substantive changes. The more substantive changes come in subsection B. And in subsection B, we're looking at how that individual is transported. And you'll note that currently, in current law, a law enforcement officer or a mental health professional may take the person into temporary custody. This language strikes or mental health professional. So it would be a law enforcement officer who may take the person into temporary custody. Then it specifies and transport the person to a hospital, police barracks, or another safe location in accordance with section 7511 of this title. And we'll look at that next. The law enforcement officer or mental health professional shall apply to the court without delay for the warrant while the person is in temporary custody. I wanted to flag for you that the term mental health professional is defined in statute to mean a person with professional training, experience, and demonstrated competence in the treatment of mental illness, who shall be a physician, psychologist, social worker, mental health counselor, nurse, or other qualified person designated by the commissioner, meaning the commissioner of health. So that's a defined term. In subsection C of this section, If the judge is satisfied that the physician's certificate was not available without serious and unreasonable delay, and that probable cause exists to believe that the person is a person in need of that emergency exam, the judge may order the person to submit to an evaluation by a licensed physician for that purpose. So again, the change here is a gender neutral change and adding licensed before physician. And subsection D, if necessary, the court may order the law enforcement officer to transport the person in accordance with 7511, so we're adding a cross-reference, to the hospital for an evaluation by a licensed physician. And then in subsection E, a person transported pursuant to subsection D shall be evaluated as soon as possible after arrival at the hospital. If after evaluation, the licensed physician determines that the person is a person in need of treatment, the licensed physician shall issue an initial certificate that sets forth the facts and circumstances constituting the need for an emergency exam and showing that the person is a person in need of treatment. Once the licensed physician has issued an initial certificate, the person shall be held for an emergency exam in accordance with section 7508 of this title. If the licensed physician does not certify that the person is a person in need of treatment, the licensed physician shall immediately discharge the person and cause the person to be returned to the place from which the person was taken or to such place as the person reasonably directs. So you'll notice in that last subsection E, we're not making substantive changes. We're doing a conforming change of adding licensed before physician and also making gender neutral changes, removing he or she in favor of a licensed physician or the person. So that is section 1. Moving on to section 2, this is section 7511 that was cross-referenced twice in the above section. And this has to do with the transportation of individuals in need of psychiatric care or potentially in need of psychiatric care. So in subsection A, the commissioner shall ensure that all reasonable and appropriate measures consistent with public safety are made to transport or escort a person subject to this chapter to and from any emergency department or inpatient setting. Language being struck, including escorts within a designated hospital or the Vermont State Hospital or its successor in interest, meaning the Vermont Psychiatric Care Hospital, or otherwise being transported. And then the language currently reads that this transportation has to, the commissioner has to ensure that the transportation is in a manner that prevents physical and psychological trauma, respects the privacy of the individual, and represents the least restrictive means necessary for the safety of the patient. Subsections B and C are unchanged, so I'll skip over those for the moment. And the larger substantive changes in subsection D, it is the policy of the state of Vermont that mechanical restraints are not routinely used on persons subject to this chapter unless circumstances dictate that such methods are necessary. That's existing law. And then the new language proposed, if a law enforcement officer or mental health professional deems it necessary to use restraints, soft restraint shall be considered as a first option. A law enforcement officer and mental health professional shall have soft restraints available for use, and mechanical restraint shall not be used as a substitute for soft restraints if the soft restraints are otherwise deemed adequate for safety. And then the bill, if enacted, would take effect on July 1, 2023.
Okay, thank you. So Katie, just looking at section 1 and then section 2. Section 1 is if someone needs to be taken for a psychiatric evaluation and how that would take place.
This is, yes, it's before any involuntary commitment for treatment has occurred. This is the initial step to get somebody that first evaluation, and it talks about the process and how the transport would occur.
And then the second one is if the individual is being transported somewhere else, not for an initial evaluation, but it could be Could it be the initial evaluation?
It could be. This just governs transportation
Yeah.
of individuals in need of care generally. So it could be somebody who's already who's on an order of hospitalization or an order of non-hospitalization, and they're moving to a new facility within the system and they're being transported. It could apply to somebody who is coming in for their first evaluation for the first time and they're being transported. So it could cover many situations. It just governs how the transportation should occur.
Okay, thank you. I think that helps sort of clarify what those two sections are doing. Questions committee. Senator Williams.
Can somebody define a soft restraint? What are we talking about?
So will we get that during testimony perhaps? So let's hold,
Okay.
that's a great question. And we do need to hear that. Sure.
What is the genesis of this bill? Why is it being there? We just voted on S-36, healthcare workers,
Yeah.
This sounds like it could be.
It may be related. I mean, there could be some relationship there. So let's get the testimony and then hope that your questions get answered. If they don't, we'll reach out for a friend. Yeah. Good questions. Other questions? Okay, Katie, thank you. That's very helpful. And so we'll turn to folks who are with us. Dylan Burns is here from Vermont Care Partners, and you're first on the list. Is this order okay with all of you as we're looking at this? Good?
Yeah, I think that we kind of have a plan to testify together.
Okay,
Kristen
so do
Chandler.
it, just why don't you do it the way you'd like? If you want to bring two chairs up, that's great. And we have the screen up there. The screen, everybody's sitting together at the end of the table now. It's great. Literally. Okay. So, do we have your testimony on our webpage?
Yeah.
We'll get that. All right, great. Excellent. Introduce yourself for the record and then we're listening.
So for the record, my name is Dylan Burns. I'm Mental Health Services Director at Vermont Care Partners, which is the trade association that works on behalf of the designated agencies.
My name is Kristen Briggs. I'm the Program Director of Access and Acute Care at the Clara Martin Center, one of the designated agencies covering generally Orange County.
Just down the road.
Randy Littlefield has some pre-recorded testimony that we're just going to show you. So she's from the Howard Center. She's away this week, but recorded this on Friday afternoon.
Okay, are you going to do that first or are you going to? Okay.
Pretty
Whatever way you want.
much. But I wanted to give Kristen a chance to
Fine.
answer some as well.
Good morning. I'm Kristen Chandler. I'm the coordinator of Team 2. I got to meet all of you folks a few weeks ago during Mental Health Advocacy Week. Thank you for having us.
Thanks for being here.
So just to address the question of where did this come from, we meet monthly as emergency services directors, Kristen and her colleagues, and in some communities there had been some issues that came up in the field, which you'll hear about a little bit. And when they went back to the statute, they realized, oh, that's the source of truth, and the source of truth wasn't really reflecting practices on the ground. So that's where this came from. Just to advance this. This is the map of our designated agency system. So each agency has a certain region that they cover. And what our goal today is, in terms of offering edits, is just to clean up the language to prevent confusion. We're not trying to alter anyone's rights. We're not trying to assign new responsibilities. The soft restraint piece is a piece that we'll get to that came out of the work group. So a little history was that the current warrant statute was written in the context of kind of a different mental health system in the state of Vermont. And it's really evolved to a more decentralized system. And so the specific problem is that in terms of who's responsible for transporting individuals, because it doesn't reflect current practice, that's led to some problematic situations on the ground and to some unsafe situations for mental health providers. So I am going to turn to Brandy here, and we'll see if this works, and we'll see if the volume works. That's so Brandy Littlefield is Assistant Director of First Call for Chittenden County, and she also oversees community outreach programs. Okay, so she started speaking, but we couldn't hear, so.
Here, let me try to share mine.
Is there a sound thing on yours?
Oh,
It's not, I don't see it on the toolbar.
should I unmute?
Looks like it's not even end. It's not working.
Oh, that's.
Share sound.
Littlefield. I'm the Assistant Director for First Call for Chittenden County, and I also oversee the community outreach team here for Howard Center. For those who are not familiar with First Call for Chittenden County, we are the crisis team that serves all individuals across the age spectrum, regardless of diagnosis. So we want to make it really clear up front that this legislation is about making the laws clearer and up to date with what current practices are actually looking like. We're serving individuals who may be vulnerable due to their symptoms of their mental health diagnosis. We serve a far greater number of individuals overall that these statutes do not or will never pertain to that we're speaking of today. However, as it is our responsibility to keep our community and neighbors safe, there is a very small percentage of individuals that require greater measures due to safety risks. The laws that we are discussing today are only for those where it's determined that the person is in need of treatment, is involuntary, and they pose an immediate risk of harm to themselves or others in their community. Again, I want to reiterate that this is a very small percentage of our overall client work that is done within our communities. And when it happens, the situation is acute and it requires swift action to keep everyone safe. The changes that we're proposing are about reinforcing most trauma-informed practices so that least restrictive methods are used. For example, soft restraint versus mechanical restraints wherever possible. It's also about keeping everyone safe and not delaying necessary care and access to hospital care as a result of confusion of who will provide the emergency transport. And if I also could take another moment just to explain what the process looks like slightly for any of you who may not be familiar. Our current process for individuals being seen in the community is that a warrant cannot be obtained unless a licensed physician is not available without serious or unreasonable delay. If a licensed physician is available, then per statute, we're required to complete an emergency examination in the field that would allow for transport of the individual to a hospital or care facility. If a licensed physician is not available, then we're able to move to a mental health warrant in the hopes of serving individuals who are experiencing vulnerabilities due to their mental illness that is put in either themselves or others in harm's way. And I thought it would be helpful to give a bit of an example of what that has looked like at times on the ground due to the challenges that we are having with the current language that is in the statute. So we had a situation where an individual was deemed to have met criteria for being a danger to others. And this was during the daytime and their psychiatrist was available. We were able to obtain the physician's portion of the emergency examination, which is the EE, to complete the EE process, the first of the EE process, as we were also able to complete the QMHP portion, which is the qualified mental health professional portion that clinicians are able to do once they have received this credential. Upon delivering the EE to law enforcement, they were unwilling to serve it as they stated that the current documentation of the law did not give them clear authority to transport the individual, and therefore they were unwilling to serve it. As we had a live EE in place following the current law, we were forced to wait for the time to arrive when the psychiatrist was not available in order to write a mental health warrant so that the law enforcement team felt like they had the necessary legal protections in place in order to transport the individual. Law enforcement was not able to remain with the individual during this process, which left others in risk. And lastly, I just wanted to point out that mental health clinicians are not equipped nor able to take someone into custody to do involuntary transportation. And it has certainly impacted our ability to even have individuals want to come in and join in our forces to serve the population when they are fearful around their own safety and well-being. And I want to end on that there are times that because the law is written in this way that the person in need of help does not get transported or get the help that they need, or they have mental health clinicians have felt like in order to get the person help that they may have to put their own health and safety at risk in order to get that person to where they need to be in order to ensure their safety and well-being. Thank you.
Oh, please say thank you.
That was
That was a lot in a short period of time.
Yes.
But we do have access to that on our webpage, so that'll be helpful to go through it another time.
So I know we don't have very much time. I will just say in response to these kinds of issues in the field, we convened a work group between March and September because we knew that, you know, the warrant statute is it impacts all sorts of parts of the mental health system. So these are the folks that were invited. Most of them attended most meetings, some more in a monitoring role, some actively engaged, and we worked through some suggested language changes, some of which you see in this proposal. I will note, we also just talked about the term warrant, because often people associate that with kind of a criminal association. We talked about potentially emergency transport order. As a group, we didn't spend a lot of time on that or reach consensus, but I'm just noting that that can create confusion for people subject to the warrant or their family members as well. So I'm going to let Kristen walk through just a couple specific comments on the
Just
changes.
go back one page.
Yeah, please.
Just to that bottom paragraph. Emergency transport order. So we could make that change, is what you're suggesting. And it actually feels better when you have that for the individual who might be subject to that transport.
Especially in light of the other bill we're working on.
Exactly.
So I was mixing
Right.
that in my head and thinking.
Exactly. We'll probably follow through with that recommendation, especially given the group that's making the recommendation pretty solid, so.
Yeah, and I want to be clear that we didn't get full endorsement from that list of people.
No.
But it was part of our discussion.
So, yeah, we just walked through some of the changes that were in front of you earlier, but as Dylan just mentioned, we had proposed some slightly different changes, so we'll bring your attention to the screen probably for those rather than what's in front of you. Is that right? Yeah. So regarding 7505B, we support this revision because it indicates that only law enforcement and not a qualified mental health professional would be the one to take a person into temporary custody. And so you'll see here for, it says if necessary, the court may, if necessary, the court may order the law enforcement officer or mental health professional to transport the person. So we are asking that mental health professionals not be court ordered to transport someone. This doesn't take off the possibility that they would be potentially transporting someone if it was deemed safe to do so. Every piece of the transportation discussion involves a level of safety planning on what makes sense for that individual that's in front of us at the time. So I just want to be clear, we're not saying that a mental health professional would never transport the person, just would like to see it revised that they are not court ordered to do so if they're strongly feeling that it's not safe. And then I just wanted to revisit B because I kind of skipped over that, I think, that, you know, when we're talking about actual temporary custody, as a mental health professional, there's nothing that we're able to really do to have somebody in our custody or keep somebody in our custody. So that's why we were saying to support that change. Thank you. And then also, again, the work group discussed the edit. A lot of the work group members wanted to leave the language for the QMHP transport. But as we're noting here, S47 doesn't preclude the QMHPs from transporting. It just limits the judge from ordering them to transport if they're feeling it's absolutely unsafe to do so. So,
Understood.
okay.
So there's a judgment to be made about the level of safety. in that.
Yes, the clinical judgment that's it's taking place already, and then what would happen from there if we're not
Clinical.
reaching agreement. And just speaking to 7511, we were wanting to clarify with better language or language that makes it more clear. Thank you. And so the commissioner shall ensure that all reasonable and appropriate measures consistent with public safety are made to transport or escort a person subject to this chapter to and from an emergency department or inpatient setting. We're proposing that the rest of line 15 and almost all of line 16 come out, which states includes escorts within a designated hospital or Vermont State Hospital or successor in interest of otherwise being transported. Because removing that, we feel makes it more clear, and we're understanding that it's applying to any circumstance where somebody in need of treatment is being transported. And naming the specifics goes back to speaking to previous history of over 50 years ago of what existed at the time and what may exist in the future, and we're beyond that. So it helps clarify and take out confusion of what we're talking about.
Okay, so it's different from what we're looking at here. So
Yes.
you're suggesting an amendment after the word use, for use. And on line 13 of the bill we're looking at, and then insert as a first option.
Yes, and that's for 7511A. Right.
And so, yeah, so this is helpful. We'll have to run these suggestions by our legislative council.
Yes, and I think we did think she had also proposed that edit, but then hearing her read it earlier, she read it as unedited. I don't know.
I think that as drafted, it's good.
Okay, all right, I'm sorry. I might have
As
just
drafted,
lost it.
it's okay?
Yeah.
Okay,
Okay. My apologies on that. And then, so I'm gonna move on to 7511D, where we're talking about, and I know there's some specific questions about this. The soft restraint language came from our work group discussion. We felt strongly that several years ago now, there had been piloted soft restraint usage by law enforcement in the state as a less restrictive means of securing somebody who may be vulnerable in a moment, but not feeling that mechanical restraints would be necessary to ensure safety. And so we wanted to take this opportunity to incorporate that language in so that we could follow. If you look at lines 18, 19, and 20, transportation, we're looking to prevent physical and psychological trauma, respect the privacy of the individual, and represent the least restrictive means necessary for the safety of the patient. And so the introduction of soft restraints into statute would meet specifically 1 and 3 out of those criteria. It would be the least restrictive means possible, and it would be preventing trauma for the individual. So our specific proposal is a law enforcement officer shall have soft restraints available for use as a first option, and mechanical restraints shall not be used as a substitute for soft restraints if the soft restraints are otherwise deemed adequate for safety. Meaning, our proposal is that they're available, that soft restraints are available, and that mechanical restraints are only used if it's absolutely necessary for safety, not just because someone happens to not have soft restraints with them.
so on 7511D, are you suggesting striking that first sentence then? Yes.
And
Yes.
part of the reason is it seems to imply mental health professional may have or be using soft restraints, and we are trying to get away from the mental health professional having that role of restraining or transporting a person.
I understand.
And that is also not something we're authorized or trained to do, so it's also not happening that we're doing any type of
We'll
restraint.
have to just talk with our, we'll have to talk with our ledge council to make sure the language fits. Go ahead.
Just following up on Senator Williams' question, is there a statutory definition of soft restraints?
You know, I know that mechanical restraints historically are the metal kind of shackle. It can be wrist or a combination of wrist and ankle connecting to each other. And it's truly just the mechanical, the metal restraints. And so soft restraints are a few different versions, but I don't know that we have a definition in here of specifically ones we're talking about, that they're truly soft, they're made of fabric versus metal.
Metal, yeah.
Yes.
I mean, I sort of guess what they are,
Sure,
but I'm wondering
sure.
if we might want to
Wanna
have a
put a
specific
definition.
Yeah, that's a good
definition there.
point. We probably should think about definitions of
Mhm.
some type.
If you're okay with me jumping in here for just a second, I don't believe there is a definition in statute yet of soft restraints. And I just want to point out, and to be perfectly transparent, that currently not every law enforcement agency has soft restraints.
Right.
Several years ago, the Department of Mental Health paid for and provided all the Vermont State Police barracks with 2 sets of soft restraints. But some of the, especially the smaller departments, do not have them currently. They do take the same handcuff key. And I don't know how much they cost, but just so you're aware, not everybody has them.
Okay, that's good to know.
So they're partially available, and part of our proposal is that they're available.
Yeah.
Policy would suggest that people carry them around.
Right now, if somebody were to be, let's say, on the ground right now, if this were to take place and it were to be determined safe for a person to be able to be restrained using soft restraints versus mechanical, if the officer involved happens to not be one of the officers who has soft restraints, they're going to be mechanically restrained versus, have the mechanical restraints used versus the soft restraints. So we're proposing that not happen.
Okay, thank you.
I assume that if Ledge Council takes this last paragraph and incorporates it, that whole shall will get clarified, because shall means they need to have the soft, every law enforcement officer would be carrying the soft.
That's a clarification, right? Shall have.
So we just have
So
one
here's a
more.
question that I have for you.
Sure.
Suppose a law enforcement officer doesn't have soft restraints, but suppose the qualified mental health professional does, or they're available in an ED, for example, or a facility of something, not an ED, we're not taking there, or where we're taking them. So the law enforcement officer wouldn't have to have them, but could certainly use them.
Yes, and I would say that I can't envision a scenario where a mental health professional would have restraints on them because we don't use them by practice or by training. So.
In the process of testimony, will we have the opportunity to have a law enforcement representative come in?
We can do that.
I think it would be this whole scenario of, okay, you're kind of like creating a dividing line between the two activities. I just want to make sure the other side is like fully capable and acknowledges this is an obligation that they can handle. That's all.
And that they have the training to be able to do it.
Yeah.
Yeah, absolutely. And I will say that there was some law enforcement involvement in discussion. So this won't, but I also hear what you're saying. Yes, to make sure that there's alignment on the practice.
Yeah, I did see that list, but it made me a little nervous when you said that we did not get the full endorsement, it's on slide 3. And I wanted, so we really need to understand who found objection with the elements of this and why and how we mitigate that as we receive testimony.
Sure.
I can speak to that just briefly. I sent proposed language out and just didn't hear back from so I heard back from the hospital association that was supportive and didn't hear back either way from anyone. So we didn't get any kind of written feedback against, but I will say, I do think the person representing the Sheriff's Association wasn't sure about the soft restraint language and said he would have to go back. So I think it totally makes sense to get input from others.
So the Sheriff's Association was involved, was the Agency of Public Safety, Morning Fox,
Yes.
he was involved in this, so
Yeah.
maybe those two are the folks to invite in.
Yeah.
Okay.
We just had, I think, just wanted to invite Kristen to just make a comment to wrap us up around training.
Good morning again. Thank you. So as you know from my previous testimony, I hope maybe you retained it, that I do a lot of training around the state and have for the last 10 years in Team 2 training, where police are present along with mental health crisis clinicians. And we spend every single training. The warrant language is incredibly confusing to law enforcement officers, and this will help clean it up. And I was a big proponent of changing the name of it from a warrant to the emergency transport order to try to help steer people away from the idea that this is some kind of criminal action. I want to point out just briefly on page 2, lines 7 and 8. This was my my particular concern and what I'm really advocating for, to clarify so that law enforcement knows very clearly that they shall apply to the court without delay for the warrant while the person is in temporary custody. Without that additional language of while the person is in temporary custody, what is happening out on the street is some officers think that they have to sit roadside in a snowstorm, in the elements, whatever, with a person while they're applying, before they can take the person anywhere. And this, I think, will really clarify that it's okay to take them into custody, which would also mean transporting them to the hospital or to a safe location. And then we have the language that's already been in there that says shall apply without delay for a warrant to cover that will happen immediately. So that's really my point, is that I think it will really help with the training, and this additional few words on this end of this sentence on line 8 will really clarify for officers in the field what they can do. Thank you. I'm happy to take any questions. I was going to suggest that when you have an officer come in, have them bring a set of soft restraints so you can see how they work.
Good idea, thanks. We'll do it. Senator Gulick and then Senator Williams.
2 quick questions. One is, how long is the period of time to receive a warrant typically?
So it honestly, it depends on the time of day that we're applying for a warrant, because judges are in court during the day, and typically the on-call judge is not in court at night. So if a warrant happens during the day, it could be hours before it's reviewed by the judge. And then the process still needs to happen for law enforcement to then work with mental health to get the person in to where they need to go. So it varies, but right now what we're facing on the ground is, because of some of the language confusion in the statute, it could be days before law enforcement go out to actually try and bring the person into that temporary custody that we've been talking about. And that is even after it's been approved by a judge. Of course, there's times where we apply, we're waiting for the judge's response, and law enforcement might not be willing to bring the person into custody because it's unclear whether they can or not temporarily while waiting for the approval from the judge. But then there are also times where it's been approved by a judge and there continues to be a delay because it's not quite clear what action should be taken from law enforcement.
So the warrant's typically maybe a few hours.
Yeah, the process does not tend to be under 2 hours generally, as kind of the minimum for everything getting written up, sent to the judge, and then waiting for the actual confirmation back and all of that. Yeah.
Got you. Thank you. And my other question was around the representatives that you asked for approval or input. If you don't hear from them, do you take that as tacit approval or acknowledgement, or how do you do that?
Yeah, the work group was interesting. There were people who were really actively engaged and people who I think had more of a monitoring role. They wanted to keep track of the discussion, but maybe we're not interested in going on the record in that context. So it would just depend on which group you're talking about, which individual.
Great. I would also just quickly share that it was not a brief or a quick process. This took place over the course of several months. So there was a lot of discussion and opportunity for discussion from everyone. Yeah.
March to September. Yeah. Senator Williams.
Just conceptually, I understand it, I support it. I haven't been through a process like this before. It's not going to happen in 2 hours. Sometimes, particularly in a rural area, I can remember going to the state's attorney's office at 2 o'clock in the morning, trying to get a warrant.
Mhm.
And, you know, I guess it depends on the situation, how it precipitates, but generally, this would have to have some lead time before it could happen anyway. But if it's an immediate thing, I don't see how, in some cases, to protect the patient and law enforcement, you may have to use hard restraints.
Yeah, absolutely. I think when I speak to the 2-hour piece, I'm really speaking about law enforcement has already started this process. They've let us know to meet us at the barracks. We get there, everything happens seamlessly. We electronically send it to the judge. They electronically send it. Like that would be, if everything went perfectly, the minimum would be 2 hours, and that's rarely the case. And I appreciate you speaking to that as well.
And last question is 7505B. We support the revision that indicates that only law enforcement, not qualified mental health professionals can take a person in custody. What does indicate?
I think just stating, like, the idea that mental health professionals take a person into custody doesn't make sense, doesn't jive with our training practice, so.
Can I just add to answer the senator's question or to just comment on it, is that not every state's attorney wants to be involved in a mental health warrant. So it really depends on the region, but completely agree with you that for most law enforcement officers, when they hear that they're going to need to deal with a mental health warrant, they're looking at 5, 6, 7 hours. They're thinking this is going to take a long time. And what Kristen Briggs described was really the ideal situation.
Just a couple of questions. So when you started your presentation, you commented that this represents a small percentage. Adjectives like small and stuff don't really help me. What, like in a year, is it 10? Is it 100? Is it 1,000?
Sure. I can tell you, I don't have the data in front of me, unfortunately, but I can say that mental health warrants in the community are the smallest percentage of people that we serve as a DA system. So we've got voluntary, people who are voluntarily engaging in whatever our process is for lethality assessment and ongoing treatment or safety planning. And then we have folks who maybe are involuntary, but they're in a location where there's already a physician, like an emergency department, a designated agency office location where there's a psychiatrist available. And then there are the smallest number of folks who meet criteria for involuntary, which are in the community where there is no licensed physician available. And we're going through the warrant process. And that's really if they truly, through the process of us trying to engage with them, remain involuntary. There are times where we think we're going to be moving in this direction. We do a lot of proactive engaging in conversations with our law enforcement partners, and we all have a very solid plan, and then the person ultimately ends up deciding to come with us voluntarily, then we go with that. This isn't a definite process once we introduce it as a possibility, of course. So this is really the smallest number of people that we're serving as a DA system. We're talking about with the mental health warrant specifically.
I want to add that it also depends on the county. I got to say that for years, because remember, a warrant is the way to get somebody to a physician who doesn't want to go. And for years, Orange County had a psychiatrist who would come to the patient. And so they hardly ever wrote any warrants because the physician would come to the patient. And then there are some counties where there's just certain officers have, more skills in talking people into going voluntarily, or as Kristen just pointed out, certain crisis workers are able to do that. And some counties allow their officers to use things like cigarettes or food in order to get somebody to go voluntarily. Other counties, other police agencies may have policies completely against that. So that's what I've seen, is that some police agencies are really good at it and some aren't so great. So then we're going to have to resort to a warrant. And it's the last resort for everybody involved.
It's the last resort for everyone involved. And I can say for Claire Martin Center specifically, I can give you data, just not for this entire state, but for Claire Martin Center, there have been many years where we didn't have any warrants. or we had only 1 or 2, but I think we're always under 5 for a year. It's just not a standard, it's not a standard practice. And we're a very rural catchment area, so that speaks to where we're hoping this is needed.
Senator Hardy, one last question. We might have to bring folks back in for further discussion. This is really very good.
Yeah, well, 2 thoughts. One, just based on what Kristen just said, and the differences among counties, and that some officers are skilled at it and others aren't. It sort of leads me to think, 1, we need better training, and 2, we need a consistent statewide policy on how these are handled, so that it's not different by county. Doesn't depend where you live. And 2, I'm wondering how this bill might potentially interact with the other bill that we're working on, if these are transports to an easy. And somebody doesn't want to go, if it's, and are we fixing one problem and creating another one, or how do they interact?
So that will
I
be.
think those are great points, and I think we're all happy to come back if you need us to.
Yeah, I think we might be doing that. I think this is a really healthy discussion and very helpful. And the question raised about having a statewide policy, I think is very important. And I've talked with the Department of Mental Health about this many times, and what can we do? And how can they work together with the Agency of Public Safety, so there's some continuity and cohesiveness around our policy.
I will say Team 2 though is also the location where law enforcement mental health get together and do scenario-based training exactly to talk through best practices.
That's what Kristen is.
That's what Kristen.
Yes.
Yeah.
Yes, we did hear your testimony a couple of weeks ago, so that's been really helpful. Okay, well, I think we're going to just sort of close this one up for a little while. It's still open, but we're going to move on to childcare. We've got a lot of work to do on that bill, but appreciate the time and effort that you've taken to bring us this bill in the first place. We've had months of work, and we will circle back to this. Thank you.
Thank you.
Thanks for having us.
Thank you for having us.
All right. And Mary, we're going to be behind schedule, so just so you know, you're probably going to be hearing a lot about childcare.
Terrific. Love hearing about childcare.
All right. So Katie McClin is here. And we're going to move on to S56, which is our childcare bill. And Katie and I did work with Katie. I also talked with Nolan over the weekend. Actually, I didn't get to talk with him until Monday, I think, but anyway, we worked on a process for us to make some decisions about the child care bill. And this is a list that Katie's put together based on a conversation where we have decision points to be made. So this list is probably not complete, but it is significant to what we need to discuss as we go through the bill. And we're, just as an FYI, Nolan and Joyce Manchester will be coming in this week. I think it's tomorrow on our schedule. So we can begin to look tomorrow morning at 8:30. So we can start looking at some of the financial pieces and make decisions there about CCFAP and others. So Katie, I will turn it over to you and we can go through some thinking about the bill.
Sounds good. Thank you. I'm sharing my screen. And it looks like you had maybe hard copies handed.
We do.
Okay, handed out too. Great. So let me just tell you first what this is and what it isn't. This is a non-exhaustive list of questions that the committee may want to discuss, may want to reach a decision on before moving forward with the next draft. I've tried to highlight the areas where it seems like there are a lot of questions that are being asked and decisions that the committee would need to reach to move forward. There may be some areas where the committee chooses that it doesn't want to focus its energy on a particular issue, maybe a particular issue won't be part of the final bill. So what I'm saying is just because it's here listed out doesn't mean that it has to become part of a committee amendment in the future. But for the time being, I've just tried to flag various points of conversation that the committee may want to have. So you'll see right off the bat, I have pre-K and I didn't put anything underneath it because I know at this moment in time, you're sort of pausing on that issue while your colleagues and Senate Education are looking at that issue. So no questions to review there, although I recognize there are a lot of questions about how to proceed on that topic.
Katie, you know what might be helpful is to put the bill up itself because, and then as we go through the list, we can look at what's in the bill and we might be able to make some decisions.
Okay, let me pull up the bill. Do the amended version? Let's do that.
Yeah, I have draft 1.1.
Oh, this will be tricky because I don't have a hard copy of this, but I can print one. Hang on. Why don't I print a hard copy of my list?
Okay.
And then I'll have that in front of me. So once I share my screen, I can't access the other document.
Yeah, I was just thinking if we have this list and then if we can look at the language associated with it, it will make it easier for us as to decisions or have a dialogue.
Yeah, understood. Okay. Let me pull the amendment up and then you'll have to excuse me while I run to the printer.
Okay. How long will that take?
15 seconds.
I was gonna say we could take a break. You can go fast. Break in place.
There's a lot of junk food around back.
Okay, we're in business.
Okay, here we are. Wow, that was
Okay. So let's dive right into childcare. And I think I have probably put the trickiest piece first, and that's the Child Care Financial Assistance Program. The first sort of topic to cover is the group of folks who would have zero copay under CCFAP. So the bill, current law says that if a family is at or below 150% of FPL, there's no copay. And then the bill proposes to increase that to 185% of FPL. Those families would have no copay. So the question is that the correct number and when should it take effect? This particular section.
What I'm going to suggest is if there's a disagreement, then say something. But otherwise, we'll stick with what is in the bill.
What do you mean? A disagreement with what's in the
With
bill?
what's
or
in the
with
bill.
Oh, okay.
Yeah, I mean, if you think 185 should be 225, you know, that's fine. I don't think we. Go ahead.
Okay. And the next question was when should it take effect? It currently takes effect, and the bill is written as July 1, 2024. The next issue is the upper income limit for the eligibility and whether the amount that should be expanded. And we can go over these questions, but I'm anticipating that you can't answer these questions until you've heard from JFO. So the bill is introduced, increases the upper income limit for families that can participate in CCFAP from 350% FPL to 425% FPL. This takes effect this fiscal year, so July 1, 2023. So I misspoke about the zero copayment that takes effect this year, the 150 to 185, July 1, 2023. And then this bill, is there?
We just asked one question. So I kind of lost track on whether we're talking about a sliding scale versus a cliff, or if we're talking about cliff.
There is currently what is termed a cliff in the bill after the first, there's a cliff right now in current law at 350. And then the bill would move that to 425 in the first year and then 450 in the second year. So it would be somewhat less of a cliff because there are fewer people above 450 than there are above 350, but it's still a cliff. And I was just passing notes with.
I wanna just share for a minute. In conversations that I've had with Nolan and in talking with Chair of Finance, one of the biggest concerns is the cliff. So when you get to, let's say that we have 425% of poverty in place, receiving a subsidy up to that point. And then after that, as income goes up, there's no subsidy. That's the cliff that we're talking about. And so the people above that are paying a higher amount for their childcare. It could be significant, could be a significant change. So one of the things that we're thinking about is the slope to try to attenuate, mitigate that cliff. This language here, the 185% is just a place where you receive total, you have no copay. Okay, so that's 185, no copay. You still have to put, you may still have to put something in. 425, you would have an adjusted subsidy. You still have to put money in.
We'll get those numbers at some point.
So we're gonna have Nolan, as I said before, Nolan and Joyce will be in tomorrow. So we can look at those numbers together. Today, we're just going through and reminding ourselves where the questions are. And so what I'd like to do, I don't want to have to answer these questions. I'm gonna let Katie and Nolan answer these questions. We'll move along a lot faster.
So for the record, Nolan was my fiscal office. So tomorrow Joyce is going to present you with some visuals so you can kind of see what we're talking about. I don't think we're going to provide you with solutions. I think this is the start of the conversation. Once you see the visual, you can start saying, okay, what if we do this? What if we do that? That's the policy that you guys decide. But I think just having a visual will strongly help visualize the clip.
All right, we're good. Okay, Katie.
Okay, so the next question under this upper income limit question is adjustment to fee scale structure. And I think that's meant to capture the very issue you're talking about right now. Is there a way to address the cliff? And if so, what might that look like? So we're sort of sticking a pin in all of these questions until you receive more information from JFO and can base a decision on that. In the bill, there is language about that requires DCF to offer electronic CCFAP applications. And that would take effect July 1 of this year. I think you did hear some testimony on the feasibility of that. So I was just flagging that as a decision point to come back to. The next sort of topic area that the committee may or may not want to address is the idea of a workforce compensation plan. So if you remember, the bill as introduced requires DCF in consultation with AOE and Building Bright Futures to develop a compensation plan, and it is in rule and it's adjusted every year. So
what page is that on?
Let me scroll down.
That's on page
4 of the amendment.
Yep, they met.
Oh, and I misspoke. I said AOE was involved. It's the department and Building Bright Futures are involved. So I think one of the initial questions is, do you want this compensation scale? I think another question is, okay, if so, who should develop this compensation plan? Who are the right people to have at the table making those determinations? What criteria should be considered in developing the compensation scale. Right now, the language in the bill talks about a scale that's comparable to compensation received by early educators in a public school system who are working with children pre-K through grade 3. Are there any, is that the right criteria? Should there be other criteria? Next is the mechanism for implementing the pay scale. How is it that providers would be required to use the pay scale? The bill contemplates a rule adjustment every year. Is that the right mechanism? Would it be sufficient for the department or another entity to put out a guidance document that providers have to follow? Right now in the bill, in order to participate in the Child Care Financial Assistance Program, a provider would have to pay its workforce in accordance with the pay scale. So that's sort of one piece that links CCFAP together with this pay scale. Is that the right link? Is that the right way to link it?
So,
in terms,
go ahead. Sorry.
In terms of when this should take effect, the bill proposes July 1, 2024. Is that the right date? And also, we're sort of looking maybe at 2 dates, because on the one hand, there has to be a date by which the scale is created, and we need a date by which the scale is implemented. So we have to sort of be thinking a few years out in terms of how the scale is developed and when it finally would take effect for providers.
So, yeah, so the question is that who is going to do it? So this will have to be some kind of work with AHS and also with others to sort out what the average scale is across the state in different parts of the state or different districts. So there needs to be some elaboration, something in here that improves this language, and it might set it out over time while that work is done. I don't know that we're going to be able to see it in place for 2024, whether it's done by rule or other.
And I should add, I sort of skipped over this, but the idea of how often would this pay scale be updated may be worth the committee's conversation. The bill, some kind of a recommendation I saw, I think it was in the Rand report or elsewhere, about a 3 or a 4 year review, but that's something we can talk about. Senator Hardy had a question.
Well, did you want to get into suggested language at this point, or are we just going through?
I was just getting ideas. So if you have a quick idea, that would help, and then we can get some language going forward. So
I mean, it seems to me that this, if the department is taking the lead on it, and I don't know if we've heard from the department as to whether they would want to take the lead on this, but right now it's in consultation with BDF, but it seems to me it would also have to be AOE because it's the school employee salary scale that they're comparing to it. And I don't know, maybe the Department of Labor, I'm not sure if they might have a goal.
I was thinking about that as well. Do they have that knowledge? But certainly it would be AOE and DCF or AHS generally, looking at different districts across the state. I mean, because there are regional differences and there are district differences. So this is an opportunity to really look at maybe some of those geographically based differences. So I agree with you, something like that. And then they could reach out to interested parties that would include DOL. I don't know whether DOL do this. No.
Yeah, but there are some agencies that are used to doing this kind of analysis.
So two things flagged or concerns to add to Katie's list of considerations. One is, and I was talking to DCF about this, and it makes sense to me. How do you convert wages into rates?
Yes.
Because everybody's going to be at different places on the scale and have a different payroll. at their agency, how do you come up with something? That's, so again, that goes to the questions of what the work group would have to consider. The other thing that I think DCF raised, and I kind of think it's a legitimate thing to think about, is if you have them doing both the rates and the pay scale, it's not always a good thing, because when they have the budget cuts, then they're gonna look to the rates. So it's almost like you don't always want that flex, you don't want, might not want to give
You
them
don't
that
want the clock
flexibility.
starting to happen, but, yeah, but initially establishing it, getting the information initially, I think. is
Department of Labor might be a big.
Yeah.
Yeah, because they're used to that. How it works.
Since we're, I know we're not talking language, we're talking about how
Yeah, how
to.
to-
So workforce compensation, I would like to know during our review with legal counsel, and share with us, again, precedent where the government sets workforce compensation for private entities. I just need to get my head around that. As far as like the list of questions.
Well, I'll let Katie answer that, but it seems to me that we're providing state funding here.
We also have a private component where,
Yeah,
so it's
Oh,
affecting
right.
both. In any case, I don't want an answer. I'm just saying if we could put it in a list of the
Sure.
things we need to get our head around. That's one that, to me, it's big because as a private, from a private perspective, it's very rare.
okay.
The government will tell us what to compensate our employees. I just want to,
Got it.
that analysis should be embedded in here. The answer can be, it should be what it is.
Right. Okay.
I'm not trying to get an answer.
No, you're right.
Absolutely.
You're right.
You
You're
create
right.
a list.
I got it. Katie, did you get that?
I think so. The question is, where else in statute is a workforce compensation set?
Or private organizations,
Okay,
private businesses.
Okay.
okay, I'll look into that.
All right.
So,
Do you have a drift of what the conversation is, Department of Labor, AOE, AHS, and trying to formulate some understanding of what the pay scale might look like in different areas, but then also it needs to be enrollment based, so. Anyway.
okay.
Yeah,
Should I move on to the next topic?
on the other side. Okay, go ahead, Katie.
Okay, so the next topic and group of questions is under the payment to providers who are participating in CCFAP. So the first question is attendant versus enrollment based. This bill defaults to enrollment based. Another question is whether the payments should reflect the total cost of care. And that is language that is used and the bill is introduced. And if so, if the payments to providers via CCFAP are based on the total cost of care, what does the total cost of care mean? Should it be defined? And if so, what is included in the definition?
Oh, I reached out for some help and looking at what total cost of care means when we say services and so on. And actually in the RAND report, I think it's on page 77, or in that area, there are two tables relating to total cost of care that we probably should look at. I think based on who we are as a state, we have to make our own definition at some point, but that will maybe help with that section. We could decide that total cost of care means only salaries based on type of child, age of child. There are different things we could do that would be very discrete and narrow, or we could expand to the way some other states are doing it. That's included in the RAND report.
Okay, and the other
Madam Chair?
question,
Yeah, go ahead.
I just want to remind folks, because I was reminded today, that DCF has a study coming on March 30th.
That's right.
That's going to be all about
Inform this.
to inform the conversation about enrollment versus attendance. Unfortunately, 30 days too late for.
Bill will be in the house though. So.
Yeah.
Well, there's something the House could do.
Oh, I think they're gonna do a lot to this bill, Madam Chair.
Yeah.
Okay.
okay, and then the last item under payment for providers has to do with whether to remove tying the payment that providers receive through CCFAP to the number of stars a facility has. So this bill instead links the payments to this total cost of care, which is, separate from the STARS program. So the question is that the right approach? Is that the approach that this committee wants to take?
Yeah, I know, and we heard from AHS that this was something they were comfortable with as well, so it probably makes sense to go ahead, but Senator Hardy.
I guess, and I mean, I see Sarah sitting here and she and I had a whole conversation about this.
Okay.
I'm somewhat uncomfortable with totally getting rid of I'm more than somewhat. I am uncomfortable with getting rid of the whole link to quality. I mean, we heard testimony from national experts that said to us basically, you would do better to put all your money into improving quality than doing all the stuff you're trying to do here. So I'm just wondering if the STARS thing isn't working. I hear that, but is there some other way that we can tie
Incentivize quality.
because this is the thing we have right now is STARS. So yeah. So I'm not 100% sure I want to get rid of the STARS thing. I guess I would like to hear some very concise testimony from a couple people on this issue. And I emphasize concise because I know we're busy, but.
We'll see what we can do.
Okay, thank you.
I think that if you're out there listening and you have a comment to make, that would be helpful.
Concise comment.
Concisely. Okay, go ahead, Kate.
The next topic in the childcare part of the bill is the non-citizen childcare assistance program. And so the question there is whether to move forward with the program, when the effective date of the program is. Right now, the bill has it taking effect July 1, 2024, or whether there should be any types of modifications to that program. After that is the special accommodation grant right now. And
I have a question on the non-citizen.
Not really a question, it's a comment. So being that this is a discussion point checklist for the non-citizen child care assistance program, it's not just a when, it's a why. Really need to get our head around why this is such so just want to make sure the why is on the list, not just the when.
Okay, that's gonna be hard to, I mean, you have to put that into findings of some sort.
That's correct.
The why is to support children who are in states and families who have children. That would be my why.
There is, Cheryl Mitchell might be a good person to come in and talk
Oh, you're
about
right.
this. She and I have had many conversations about this, and she can speak to the need in Addison County in particular, but I think statewide, and maybe address some of your questions.
Would you mind reaching out to Cheryl? I can have Alex reach out. We can get her to send us something in writing.
Alex, you should have her contact, but I can, I'm happy to.
Well, another question would be why not?
Well, that's it. Why and why not? It's the same question.
Sure.
Yeah.
I just want to add a comment to think about too, is that I recommend when we do the bill, when we think about the appropriations, that you allot money specifically for this program, because outreach for this population, I think we had the same thing when we did the Dr. Dinosaur-like program. You're going to want to have money in there to help outreach for this population.
So some additional
flag to remember when we think about appropriations later on.
I hope you'll bring that back.
I will bring it up.
And so, yeah, and the other thing is the date on this, not probably going to happen in 2022. But I think in the bill, Katie, is it?
It's 24 if funding, pending funding.
Yeah, so I know the agency had said it requires time. Katarina, sorry.
Katarina Lascias, Senior Advisor to the Commissioner at DCF for the record. In looking into this from follow-up from our testimony of last week, you all know that we're still building module 1 of our IT system. We would want to be able to implement the non-citizen CCPAT. That would have to be part of our IT build, which would require us to work with the current provider, IT provider, to amend our contract with them to see if this could be added. Right now, module 1 is set to be completed in January or February of next year. Adding this would add about 6 weeks to that IT contract, so it pushes, into late spring of 2024.
Adding the application.
Right, we'd have to see if they would be willing to add it, but that would be possible. If that's possible, it would put us in April or May.
Is that because you would have to link the application to the database basically, so that when somebody.
Yeah, so that we would be able to process their applications, but also have the correct IT network so that we're not recording that information in a way that we would share inadvertently with people we don't want to share that information with.
Okay, and you did say that.
6 month lease may be worth it considering how much.
Yeah.
Yeah. End up being worth the time to do it.
Yeah, I mean, we want to make sure that we agree.
Okay, that's good. I'm glad you.
That's all we wanted to know.
Yeah, that's what we want to know. If you think it's possible and.
Okay.
Shall I keep moving? The next item in the childcare part of the bill is the special accommodation grants. Right now, there is a report. Is the report collecting the correct information? Or are you instead looking to move to more of an affirmative requirement of you want the program to be structured in some way or to do a certain activity? I know you heard testimony that the department was going to suggest language on this one. So you may just wait until you see what they're proposing, but I wanted to keep that one on your radar.
If I can provide an update for that.
Please.
Well, I don't have a language suggestion right now, but I did want to let the committee know that we currently have a report agreement with Building Bright Futures to look into the special accommodation grants. So we're just trying to see if the language in the report is the same or similar to what we're already asking of from them, and to see if the deadlines line up as well. Therefore, this might not be necessary in this piece of legislation if that report is already happening.
When is that report coming?
That's one of my questions as well, so I'll follow up with the committee.
Oh, hey, that would be great. Yeah, it would be helpful because we felt uncomfortable leaving the accommodation grants out, but we didn't know what to do.
Understood.
Yeah.
And there's just a lot of angst in the field about these. They're just not working well.
Understood.
Okay, so Katie, we've got, I think we're gotten to a good place here. I'm going to suggest that I'd like to ask if we could, I think we can put a hold right here, because then the next steps are outright appropriations that we've looked at a little bit. We'll come back to governance, and we'll come back to transitional language that includes the Building Bright Futures. If we could put a hold right there.
Sure.
We'll come back to page 9 or 10 and move on to the grants, and then we'll move into the governance section after that. Is there anything else we're missing?
The government structure,
The
there's a lot
governance,
of.
there's a
smaller-
lot there, right? So we'll have that conversation. Here's what I'm gonna suggest. Chris Delia is here from the Vermont Bankers Association. And Chris, you wanted to make a comment about a section of the bill, and I know that Katie had questions about what it is you were requesting. If you could just briefly give your name for the record and state what your.
Sure. For the record, Chris Delia, President, Vermont Bankers Association. Katie and I exchanged emails yesterday, so hopefully she has a little more context. While there's existing language in statute regarding the department to get access to financial records, that's old language. And the world of privacy has changed since that language was introduced. This discussion in this bill is very similar to something that happened back in 2018 with access to financial records for Medicaid assistance. And we created a whole body of language in the bill that allowed for the sharing of information with the department based on the individual's consent to allow us to share that information. So we'd like to have some language in this bill that gets consumer consent before we release information to the department, which I think might be called the Department of Economic Empowerment, if I read it correctly. So there's a lot changing in this bill, and I just want to make sure that we have an opportunity to bring that language from the Medicaid bill that was appropriate and get it into this bill so that we can accomplish what you would like to do.
Good, this is good. We understand. Katie, you understand, and you've received information from Chris?
I have a question. Are you proposing to strike 212 and replace it with the sections you sent me, or the sections you sent me in addition to 212?
In addition to 212.
Okay, and is the proposal also to add them in chapter 1 for consistency?
Yes.
Okay, thank you.
Okay, this is helpful. And then AHS, you're aware of this request. Okay.
Now I am.
Now you are. That's why it's great.
We can talk in the hallway because one of the issues that we accomplished in the Medicaid bill was through the application process to the state. The consumer signed off that the department could get access to the information. So that was embedded in your Medicaid application process to the state. We would suggest the same thing here. If Christine is applying for childcare assistance, I sign off that the department can get access from my financial institution. That clears the way for us, and we're not violating privacy regulations. Without consent, without authority, we're not going to put ourselves in violation of state and federal regulations regarding privacy.
That's good. Okay, good. Thank you for being here. This is
Thank you.
This is helpful. I think we understand, and it will help with the eligibility determination and keep everyone here. Okay. All right. So we're gonna put a hold on childcare. I know it's like leapfrog. That's what we do. And we're going to move on to S36.
Erin was just wondering what, so I told him I would come get it.
Oh, good. Yeah, okay, yeah. I need it. That's good. And this will be our last bill for the day. We're not on break.
So we got.
You know what? Eric, where's Eric?
Someone's getting him a fix.
Can we close the door? Because we're gonna start, and I don't know where Eric is, but I need him.
I don't know if anybody's actually.
Excuse me, excuse me.
Okay.
Devin went to get Eric.
Oh, yeah, okay.
It's tucking your hair.
Chairs have, this is a nice chair. I might just kind of, this
It's a nice.
This is
very
something
old.
It gets warm after
I
a few
was gonna
minutes.
say.
So it's heating up.
That's okay too. It's nice that it's padded.
It's like, I know,
Things are getting luxurious.
I'd say.
Well, it is.
Yes.
Run out with the riffraff in the house.
It looks like snow until 6 or 7.
Yeah, it's a lot more than I was expecting.